All right, today's lecture we're going to be going over MSK of the upper extremity. All right, so I included this as our first slide because I guarantee you this is going to be on the registry. Your shoulder anatomy and the structures that make up the rotator cuff. So we're helping Nick out with his topic. So they always ask, what are the four structures that make up the rotator cuff? And they are the supraspinatus muscle, which turns into the tendon, infraspinatus muscle. Number 3, your teres minor. You have the teres major, but it's teres minor. And then number 4, your subscapularis muscle and tendon. All right, here we have a coronal oblique, because we know with our shoulder, most of our scan planes are going to be oblique to match up with our ice cream cone. And a lot of times you're running your coronal obliques, they're going to be running parallel with that supraspinatus muscle, which turns into the tendon there. So this is a T2 weighted image. The only fluid we can see here is in that synovial cavity. We have bright signal here. It's not the best image. This is just blown up. So T2 weighted, not fat-satted because our subcutaneous tissue is still bright. The anatomy here, A, up top, your trapezius muscle. B, your acromion. So then what's this joint space right here? AC joint. I'm sorry, right here. A little higher up. Always want to include your AC joint on your shoulder images. C, supraspinatus muscle. So this is that supraspinatus muscle that you're aligning your slices with. Turns into the supraspinatus tendon. Then D, they just say rotator cuff where they all converge. E is your deltoid muscle. Deltoid, your most peripheral muscle on your shoulder. F, glenoid fossa. G is your humeral head. And then H is that subscapularis muscle. So we can only see 2 of the structures that make up the rotator cuff here, subscapularis muscle and supraspinatus muscle up here. But please memorize those 4 structures. Here we have a sagittal oblique. So now we're going to be basically perpendicular to that supraspinatus muscle. A, we have the acromion. B, AC joint. C is our clavicle. Our clavicle is what? More anterior or more posterior? Anterior. So then if we had to label, this would be the anterior side over here. This would be the posterior side. D is our supraspinatus tendon, because we're getting closer to the attachment site. E is our infraspinatus tendon. F, teres minor. Then G is our subscapularis. So you can see all of the tendons here of the rotator cuff. So you know why an arthrogram could be beneficial, because they're all kind of near that joint space. If you have any leaking of that fluid that they inject during the arthrogram into these little areas where these tendons attach, it could be an indication of a rotator cuff tear. And then here we have a crappy axial. This is a T1 weighted image because we have fluid in the synovial cavity here. It's dark. Our muscle's a little brighter in signal than it would be on a T2. A is our pectoralis muscle, so that's the anterior up here. Down here is posterior. Our shoulders naturally sit at an angle in our body. That's why for a wide view projection on X-ray, we usually rotate our patient how much? Wide view.
47.
How much do you rotate your patient?
30.
45 to 60. Tiffany wins. 45 to 60. Good job.
It's been a while.
It's been a while, huh? You guys are going back next week. So make sure to refresh on that. C is our lung. Lungs are filled with air. Air does not usually produce any signal on our MR images. What are the structures that don't produce any signal on MR? Air?
Bone marrow.
Not bone marrow. This is cortical bone. Cortical bone. Compact bone on the very edge of the bone. So that here's the compact bone right here on the edge of the bone around the humeral head. What else? Ligaments and tendons, and one other thing. Metal distorts our image. Metal artifact, signal for weight. D is our deltoid muscle. Once again, the most lateral muscle within the shoulder. E, humeral head. F, subscapularis muscle. G, glenoid fossa. H, infraspinatus muscle. And then I is your scapula. So the cone of the ice cream cone is your scapula, and then the ice cream is obviously the humeral head. Who here has struggled with your shoulders?
I did at first.
It's tough. Shoulders tough.
Now.
Alright, moving down. More distal. So we got our elbow. This is a sagittal here, and we have an axial that's based off of. You can see the scan plane as you go through your axial. Do you guys see any pathology on this image?
Fracture.
Of what?
The electron process.
Good. So A, tricep muscle, posterior of the humerus. B is your humerus. C, bicep muscle, flexion. D, olecranon process that has been fractured. F, or E, FE is olecranon fossa. So olecranon fossa, it is posterior of the humerus. Remember, that's where the process goes into when you straighten your arm. F, trochlea. G, coronoid process. C, between two nations. So here's a nation, and where's the other nation?
TMJ.
TMJ, yep. H, brachioradialis muscle, going down to the radius. I is the ulna. Here's an axial. A is your olecranon process. B, extensor tendons. C, olecranon fossa. I'm not going to go over all the names here. You guys can cruise through all this, okay? So take a look at this. We'll go all the way down the wrist. All right, so indications for our upper extremity. So most of the time, are you going to be giving contrast with MSK imaging?
Perhaps.
Sometimes.
You went from yes to sometimes.
For shoulder.
For shoulder. But is
Oh, no,
that
no.
arthrogram contrast, or is that, I'm talking about gadolinium.
If they suspect a tumor or infection, but other than that, okay, fine.
Good. So tumors and infections, really these two first lines here, this is with contrast. So if you guys want to highlight these, most of these are with contrast. If you see anywhere it says soft tissue mass also, obviously that's a mass. Could be contrast. Avascular necrosis, meaning maybe there was a fracture in your scaphoid of your wrist. The fracture area that is not getting blood supply could actually die off and necrose. Cyst, that's a benign tumor. You don't really need to add gadolinium unless they don't really know if it's a benign tumor yet. Ganglion cyst, a lot of people get those in the wrist. Carpal tunnel for the wrist. Type a lot. Anybody here ever suffered from carpal tunnel syndrome? Parents ever suffered from it? Intra-articular loose bodies, nerve impingements. You don't need contrast for these. Fractures don't need contrast. What's a good pulse sequence to visualize a fracture? What do you think? T1 or T2 to start?
T1 to T2.
What shows pathology? T1 or T2?
T2.
T2 because pathology is right on T2. And then what are some pulse sequences that saturate fat? A very uniform fat saturation pulse sequence. Stir. So anytime you're looking at fractures, stir images are great. Ligament tears, you don't need contrast. Marrow abnormalities, you might need contrast, but typically MSK, you're not going to need contrast. All right, patient prep. So you guys are going to be doing presentations on these, so make sure to look over that slide. You can use some of these patient prep slides. But the main thing here is obviously using the right coil. So if you have a dedicated coil for that anatomy, you want to use it. Sometimes they don't fit in the dedicated knee coil, and you have to think outside the box a little bit. So imagine if they can't fit in a dedicated knee coil. What are you going to use? Abdomen coil, which turns into like a large surface flex coil. So good. What if you don't have a dedicated chimney coil for the foot and ankle? What are you going to use?
A head coil.
Head coil, and you usually have to bend the knee and put the foot down flat. You have different ways to do it. If it is like an ankle, you can keep the foot straight. So you have to think outside the box. But if you do have a dedicated coil, you're going to want to use that first because that coil is going to be as close to that anatomy as possible. And do we want to use a large or a small coil? A small coil is going to give us a better signal. These procedures usually only take about 30 minutes, but if it is with contrast, 45 to 60 minutes. A lot of these have a lot of necks, meaning our signal averages are going to be going up because they want really good signal combined with really thin slices, good resolution, good signal. So these sequences and these exams usually take a lot longer than you think. Instruct the patient to stay still. Your sponges are your best friends in MSK imaging, so just even if you have like a dedicated foot coil, if you can pack in some sponges around maybe that knee, go ahead and do it because you don't want that patient to move. And then a lot of places have like the MRI safe capsules. Those cost a lot of money compared to, I think I was with Nick and they had fish oil, right? They had fish oil. Some places have vitamin capsules. I think that's just a JACO thing where they come around and they want to make sure everything is hospital specific. So. But it's just really to mark the region of interest. So anytime you're doing MSK imaging, it's a lot of slices that you're covering, so the radiologist wants to be clued in on exactly where that pain is happening. So if it is like on the lateral malleolus, make sure to put that little capsule on that side to kind of clue them in on where the pain is. All right, we'll start off with our shoulder. Here we have several different shoulder coils. You got one that goes under the armpit here, and then one you just kind of slide into. What are some tips for these types of coils as you did in clinic? What are some tips?
At the Hawks, they put a English sponge under their unaffected sides, roll them into the coil.
Good.
And they put cushions around it.
Nice. Yeah. So have you? Has anybody else utilized that tip? That's a great tip. So sometimes, because of just our anatomy, it's hard to get into that coil, so sometimes they have to dip in and straighten up. So just by putting a sponge under the unaffected side, it allows them to slide into that coil a little bit better, and it's not as painful. Because if you're laying completely on the back, that coil really starts to push against the front. A lot of people complain because it's such a hard, stiff coil that causes a lot of pain. And a lot of pain is like anterior, it's like a rotator cuff injury, that it's just pushing right on that area that's already tender. So that's a good tip. Anybody use the towel under the arm? So if you don't use that towel to elevate the arm, it's going to cause you to kind of have to manipulate your slices a little bit. And it sometimes reverses the way it shows up in hacks. Is if you angle a particular slice too much, it causes it to flip. And like if you're scanning the left shoulder, it will appear like a right shoulder. So there are ways to like flip them back, but if you don't put that sponge underneath their arm, it's not gonna. It's gonna be a little bit harder when you're setting up your slices. So put a rolled up towel or a sponge underneath the arm so it doesn't drop down too much. All right. So basically, you center right on that glenoid region. They usually have a little marker on the coil where to center it. Here are our scan planes, and I talked about the coronals. You're going to want to go parallel with your supraspinatus muscle. Your sagittal, you want to cover perpendicular to your supraspinatus muscle, going from the deltoid muscle all the way, pretty much covering the entire scapula. And then your axials, you want to get your AC joint to below the glenoid fossa. So when that humerus starts to narrow down, that's what you want to cover. Look here, you increase your necks for fat sac. So this is why these things typically take a little bit longer than you think. You have your slice thickness is 3. Your neck might be 3. Your spacing is only 0.3. So you have very thin slices for good resolution, and then you bump up your necks to also bump up your sigma. Here's your localizer. This is where they utilize that towel underneath the arm, so it makes that humerus look nice and straight up and down. If you didn't have that towel, that humerus would have this angle to it right here. Sometimes you need to do a couple localizers to get something that looks like this good, right? So your localizers in these shoulders are your best friend. So make sure you get good sagittal, axial, and coronal before you actually start your pulse sequences, okay? So if you have to run 4 or 5 localizers, that's fine. Just make sure you get some good ones. Here's your axials. You're going to be perpendicular to this glenoid cavity. And then look at here. We're covering the AC joint down to below the glenoid cavity where the humerus starts to narrow. Make sure your slice planes are nice and lined up in all directions. Do you guys use sat bands for your shoulders? Some places do, some places don't. What about for surgeons? Do they use sat bands?
I think so.
Okay. What about EP? They use sat bands for shoulders? I know Stewart does. I've seen him use them. But you want to minimize the flow from the chest. Respiratory artifact. Your sagittal oblique, you want to be perpendicular to that supraspinatus tendon and muscle. Do we want to adjust the field of view often when we're doing MSK?
No.
Why? Why do you think we don't want to really adjust the field of view?
You want to cut nothing off? Make radiologist.
Already on.
Yeah, radiologist. When in doubt, the radiologist will give you that. No, it's if you adjust your field of view, that sometimes adjusts how thick your slices are too. So, or just how big your voxels are. So it decreases your spatial resolution. So unless they have a very, very big body part, you don't really want to mess with your field of view. You definitely don't want to mess with your slice thickness on any of these, because if it's set at 3 millimeters, you want to keep it at 3 millimeters. Okay. But you can see how if you have like a patient that has a lot of fat, you could possibly get some wrap in there. So you could add some oversampling to make sure it doesn't wrap. Coronal, we want to be parallel with that supraspinatus muscle here. You want to get slices from the coracoid process to the posterior humeral head. So make sure you're basically including all the muscle. They're not so concerned about that soft tissue, that subcutaneous fat. I'm sorry. All right, your arthrograms. So in the past, when you were on the X-ray side, usually your MR techs brought the patient down, and they had that bag with the syringe, and then usually they had the vials along with it. Is that how they handled most of your arthrogram patients?
No.
How did they present your arthrogram patients in X-ray?
So like John's Creek, they just, you go and you get them from the waiting room.
Yep.
And you take them to the floor room, and you have to like set up a tray and everything. And then you call the radiologist to get started. And then they inject everything. They kind of let them marinate for a minute.
Yeah.
And then they send them to MR.
Okay, I see a little fault in that workflow. What if they did all that and then they're claustrophobic? What if they did all that and they don't even fit in the coil?
It's a very good point.
So a lot of places should be doing this type of workflow where the arthrogram patients should visit MRI first, fill out your screening form. If they indicate that they're claustrophobic, do a dry run. If they're too big to fit the coil, find a way to work around that. So always do a dry run before they actually go and get the injection, because it's pointless if they get the injection. It's almost an invasive procedure for no reason, and then they come to MRI and you can't get a good image, right? So always come to MR first, then take them to X-ray, and usually that's when the MR techs draw up the contrast for the arthrogram. And this is what's in the arthrogram. Usually it's about 7 to 10 cc's, even more to 15 cc's of diluted magnevis or whatever gadolinium you have. So here at Emory we use what? Prohance or even Dotarim. So they would want to use Prohance for most of these. You barely use any of your gadolinium. You can see how little it is. You don't need much. And then the rest is lidocaine to numb the area, omniopaque to show up on our X-ray fluoro, and then the rest is saline. So this is kind of a good formula for your arthrogram syringe. And a lot of times you would just basically go ahead and mix all these things and then put the vials like in a plastic bag and take it down to X-ray. So if that hasn't been the procedure so far, maybe they would reconsider doing it just so that they don't have an incident where they do the arthrogram and then the patient can't even do that.
That's what they did last time that I was kind of involved in the arthrogram, and that was probably 1.5 years ago. So I don't know if anything's changed. But
yeah. And sometimes, they ask them, like, as they're walking them back to X-ray, like, are you claustrophobic? So now that you guys have seen both sides, the X-ray and the MR side, you kind of get a full perspective of what happens and all the steps involved, okay? So if you do an arthrogram, make sure they're not claustrophobic, and if you see that they're kind of a bigger patient, maybe take them down to MR and be like, hey, let's see if we can do a trial, like a dry run, to make sure that they can get through this. Because at Johns Creek, I was up there with Jenny, they had a 16-year-old kid.
He was like 14.
Yeah, and he was very claustrophobic. He took his medication too soon and it started to wear off. And then they were concerned that, and they already injected the dye into his shoulder, so it's like they got to get it done before that dye starts to filter out of the joint space. So they were like, all right, make sure that they put the washcloth over their eyes, and the doctors are like telling the techs, and the techs are like, we know these things, don't even remind us of this stuff. But there is that concern that they're not going to be able to have the MR scan, even if they've actually been injected with the contrast. This is that Aber view, abduction, external rotation. So you can see here how we have the shoulders up. And this is just for better visualization of our rotator cuff area. Here's your localizer scan. This is a coronal. And you can see here, it's like almost like an oblique axial running along the length of the humerus. And then these are what the images actually look like right here. So this is how you set it up. So if you have a flex coil, you just have to kind of put it underneath their armpit, wrap it around. All right, humerus. So once again, a long, skinny bone. So what's a parameter we could use to reduce our time and maintain our spatial resolution? We talked about it with an L spine, where we have a long structure, long but skinny structure. We can utilize this for L spine, humerus, tib fib, femur. What was that? Where we remove half of the phase encoding steps.
Oh.
We go from a square field of view to a rectangle field of view. So any of these long and skinny body parts, we can utilize our rectangle field of view to fill case space. It reduces time, but we maintain our resolution. So we're basically going to be using the large abdomen flex coil for humerus. We want to have the patient with their arm down, just like an x-ray, right? With MRI, it's the same thing. We want, like for a wrist, we want it to almost be supinated. Or if it has to be pronated, due to the patient's pain, we can do it that way. But elbows, we almost want them to be nice and AP. You don't want them to have their hand rotated over, because that's going to cross your radius and ulna. So the positioning for these structures are kind of similar for your x-ray positioning. You want to have the joints to be in the same plane. You don't want to have like a lateral elbow and then a AP wrist. Because remember, you're getting joint to joint for most of these long bone studies. So for a humerus, we want external rotation. So we want to put the sandbag on the palm so that the epicondyles are parallel with our table. And then what's in profile on the humerus? The greater or the lesser tubercle?
Greater.
The greater tubercle. Yep. Here we're just putting it over the affected side. But here we're getting a lot of signal from the chest. So what do we need to utilize? Sat band and what else? Phase oversampling. Because we do not want any of this chest, because we have the coil over the chest, so we're going to get signal from it. We don't want it to wrap into our humerus. So sat bands and phase oversampling are key when we're imaging, utilizing a coil that's over unaffected anatomy. Here's our Humerus Protocol. Usually you want to get a scan in all three planes, so you've got your axial, coronal, and sagittal. We utilize a lot of proton density fat sets with MSK. Usually gives us good signal and good contrast to noise ratio for pathology. And then our fat set, because we don't want to see the fat. Most of the pathology is going to be affecting the bone. Here's our localizer. Make sure you get signal joint to joint. Lily, when do we not need to get joint to joint? I've seen you do these a couple times at EP59.
When we don't need.
Yeah, when do we not need joint to joint?
When they're only looking at a mass, sometimes they don't need joint to joint. They only are focusing on the mass.
Yeah.
What did she say?
So you want to say it a little louder?
When we're looking at a mass, like a tumor, that's when you don't get joint to joint.
So this patient's already been to scan at EP59 before, and they know the tumor's in a certain area, maybe closer to the humeral head, they don't need to get from joint to joint because they know the affected area is just in that particular part of the humerus. So you just need to cover basically the pathology and a little bit past, okay? So if it's like a tumor, that you don't necessarily need to get joint to joint. Here with the axials, you are getting joint to joint, so you gotta have a lot of slices. You could utilize that rectangular field of view. And you look at your phase directions going to be going A to P, because you don't want any of the anatomy right to left wrapping into our image. Put a sat band over the chest for respiratory artifacts. But you see here, our phase direction is A to P, so there's nothing behind the patient, there's nothing on top, so nothing's going to wrap into the image. So just be mindful of your phase direction. Oblique sagittal. This is where we want to be perpendicular to the scapular plane. So here's our scapula. You could be perpendicular to that. Sometimes they just do a true sagittal, so they just basically get from the lateral side to the medial side of the patient. It depends on where you're at, but sometimes they angle perpendicular with the scapula. Sometimes they just get from lateral border to medial border. And then coronal parallel with that structure. Elbow. We can utilize our knee coil for our elbow. Just move it over, have the patient scoot over kind of to the edge of the bed, utilize that knee coil, or a flex coil will do. Once again, we want to supinate the hand because we want the elbow to be as AP as possible. Almost like an external rotation. Center right on that elbow, the epicondyles. And then here has good diagrams on your Emery protocol of how to angle your slices. And I think I asked when I was watching Lily and Jackson scan an elbow, I was like, are you angling with the epicondyles? And she said she was just kind of going with the anatomy. Yep. But here they're saying you need to specify with the condyles. So here on the axial, you want to get a little bit above our fossa here. Which fossa is this? This one's in the front. What's the one in the front? Coronoid fossa. And then the olecranon's in the back. So we want to get above the coronoid fossa and then down below the radial tuberosity. So make sure you're covering above and below radial tuberosity. And then here, you can see how the angles are a little confusing, but you have the epicondyles of the elbow, and you want to be either, for the sagittal, you want to be perpendicular to the line drawn between the epicondyles, and then for the coronal, you want to be parallel to the line drawn between the epicondyles. Once again, looking at the protocol, 3 necks for fat sat, slice thickness 3 millimeters. Here's our localizer. You can put sat bands above and below to reduce flow artifacts from the arteries and the veins. All right, forearm. Once again, it's a long bone. We can utilize our rectangular field of view. We're using our abdomen coil. You want to position so the arm is externally rotated, so your elbow is pretty much AP, and your wrist is like a AP. Get your abdomen coil on top of the patient. This is a Siemens coil, so you have the table as also a coil, and then you have the flex coil on top. So you always want to make sure you have coil behind the part and on top of the part. Here's our planes that we need to get. Once again, we should always acquire 3 planes for every MSK procedure. Axials are covering joint to joint. Make sure you're going A to P with your phase. Add some phase wrap if you're going right to left. Your sagittal, you could angle with the epicondyles. Or sometimes some people angle with the styloid process of the radius and the ulna. Here they're angling with the epicondyles again. Coronal, perpendicular to that, 90 degrees from that. Our wrist, we have a dedicated wrist coil. You could either put it beside you, and then you're basically going to be like a lateral wrist, or you could do the Superman pose and do a PA, or you could just detach this whole thing and have the patient lay, and then you want to kind of move the patient's body away, and then just lay it. Depending on how much pain they're in, if they're pretty flexible, do the Superman. Has anybody had issues with doing the Superman pose?
Nobody likes it.
Nobody likes it. Their arm goes numb after a while, right? But nobody's had to like readjust like halfway through and do it.
Oh yeah, I did.
You've had to readjust? It happens. Here it is with the Superman pose. And the Superman pose is beneficial just so you don't get any wrapping. So you're isolating that body part. So if you isolate that body part, you don't have to worry about getting signal from the patient's abdomen that's going to be sitting right next to it. Okay? So if it is a dedicated wrist coil, it's nice because usually you just get the anatomy that's within that dedicated wrist coil. But sometimes these flex coils pick up a little bit of anatomy that it's laying right next to. Here, for the sagittals, here's the styloid process of the radius, the styloid process of the ulna. You draw a line between the two, and for the sagittal, you want to go perpendicular to that line drawn between the two. For coronal, you want to go parallel to that line drawn between the two. It's a very small field of view. You do not need to get much of the radius and ulna, and you do not need to get much of the metacarpal bones. Okay? So really just focusing and centering everything right on those carpal bones. So make sure isocenter is right on those carpal bones. You could put a sat band on the fingers and on the radius and ulna to reduce our arterial blood flow artifact. We talked about that today in our flow talk. Hand and thumb are a little tricky. Hand, you got to use your flex coil. You want to use your small flex coil to increase your signal. Try and put them in that Superman pose if you can. Using this triangle sponge is nice because it keeps all your fingers on the same plane. Otherwise, they might just kind of be a little off here and there. But you want all the fingers to be on the same plane because think about it, if you get coronal images through the fingers, you're going to have to increase the amount of slices if they're not on the same plane. So make sure all your fingers are on the same plane. So a sponge could really help with that. You wrap your coil around it, strap them in. That's what your localizer looks like. So you can see here how when you're doing a hand, sometimes they do slices just for fingers 2 through 5. And then if it's just a thumb, you're going to be acquiring different slice planes. Because our thumb sits at a completely different angle than our fingers. For a hand, though, you want to get all 5 fingers in there on the same plane, and make sure the fingers are slightly separated because you're going to lose a little bit of your fat set if they are touching. You don't want them like spread their fingers really wide because that's going to increase the amount of slices for your sagittal. But you just want them slightly separated, okay? Make sure you flip through all your slices on these because you think you've been through you're through all the fingers, but then your middle finger keeps going. You don't want to cut off any anatomy. So flip through all your slices to make sure you have all of your anatomy covered within your field of view. A lot of people sometimes say like they want to see one slice that's purely air, right? To prove that you've covered all of the anatomy. Sagittal is basically just medial to lateral, coronal. Some people angle a little bit with the metacarpals here, so you could basically add a little bit counterclockwise angle here. And that's beneficial because you'll be able to see a slice that shows all the metacarpals on one slice. So if you want to, angle a little bit with these metacarpal bones here. So you need to angle a little counterclockwise here so that all of these bones show up on one slice. Because it's always nice to have comparison. So the radiologist is looking at your third metacarpal and your second metacarpal, and they might see a fracture on the second as they compare it to the third metacarpal. And then here's your thumb protocol. So when you have a PA hand, how does your thumb naturally sit? Oblique. On an X-ray. Oblique, right? Then you usually have to angle your hand like this for a lateral, and then you have to do this whole thing for an AP, right? So we know our thumb naturally sits at an angle, so we need to think about that in all three directions. So here they say, make sure you have a line bisecting your sesamoid bone. So you have sesamoid bones near the thumb, and where else do you have sesamoid bones? Near your big toe. So here it's saying to angle, put a line through those sesamoid bones, and then basically have your slices running parallel to those sesamoid bones for your coronal. Axial, you just want to get from the tip of the thumb all the way down to the carpal bones. And then your sagittal is going to be 90 degrees from your coronal here. So then you want to be perpendicular to that line drawn between the sesamoid bones. So if you want, I would recommend positioning their thumb like this to separate these fingers as far away from the thumb so they don't wrap into the image. So kind of do it like you're doing almost like a lateral thumb in X-ray, but just lay them on the sponge like that. So, don't do anything like this, where the thumb and the fingers are super close to each other. Make sure you're isolating the thumb, okay? All right, let's go over some pathology and we'll get out of here. So here's our rotator cuff tear. What are our four structures that make up the rotator cuff?
Supraspinatus, muscle infra.
Supra, infra. What else? Teres minor and subscapularis. Infraspinatus, supraspinatus, teres minor, subscapularis. So here we have a detachment of that tendon here, that supraspinatus tendon. And you're starting to see that contrast from the arthrogram leaking into that glenoid cavity. Bursitis, so this is inflammation of those fluid-filled pads. So here we have a stir image, or it's a T2 fat sac. Here's a bursa, cushions the joints. And anytime you have inflammation on a T2 weighted image, it's going to appear bright. Okay? So that's why it's important to fat sat or have a stir image. Symptoms include pain, swelling, stiffness, common in areas like the knees, shoulders, elbows. hips. Repetitive motion joints. Compartment syndrome. This is a painful, dangerous condition caused by pressure buildup from internal bleeding or swelling of the tissue. So here we have blood, hemangioma here, causing obviously a lot of pressure on the muscles and the tendons within that area. Sometimes this pressure decreases blood flow, depriving of those muscles and nerves of needed nourishment, so we might get some necrosis of those structures if we don't do something with this compartment syndrome. Symptoms include severe pain, numbness, weakness, maybe the pins and needles feeling. So sometimes emergency surgery is needed to drain that area of that blood or excise that area. Carpal tunnel syndrome. Numbness, tingling in the hand caused by the pinched nerve. It runs right through the carpal bones. A lot of people that constantly type, secretaries back in the day used to get this a lot. Cellulitis, inflammation of the, basically the outer layer of the skin. A lot of people with diabetes have sometimes issue with cellulitis. Some people that have been bitten by cats. Cats have a lot of toxins in their fangs and just bacteria. You get inflammation of your skin that way. So we used to have to x-ray a lot of people that have been bitten by cats to see if that has turned into cellulitis. But it's potentially a serious bacterial skin infection. You don't want that to spread to the bone. What's it called when it spreads to the bone? Osteomyelitis, good. So treatment without antibiotic could be actually life-threatening. Avascular necrosis, so here we got that scaphoid I was talking about, a very common area, or a common carpal bone that fractures when you land on your wrist. Due to that fracture, we're not getting blood supply to basically half of the scaphoid, and then it necroses. Okay, so here's the fracture site, and then here's the necrosed area of the scaphoid bone. This is also very common in the hips, where a lot of people get, big fracture, they fall and fracture their hip. Osteomyelitis, that infection is spread to the bone. Symptoms include pain, fever, chills. They might have to actually remove part of that bone, so you'll see those diabetic patients that have had half their foot removed. You can always tell because you guys x-ray them, you can see that clean cut along those tarsal bones, right? The metatarsal bones. That's usually a surgical removal compared to the bone actually just healing away. So this needs to be treated either by removal of the bone or strong antibiotics for a long time. And then just a fracture. Our STIR, or T2 fat sad weighted images, are going to give us our best contrast and noise when we're trying to delineate a fracture. Here's that fracture of the olecranon process. So obviously, most of the time we can see these on x-ray, but if it's like a hairline fracture or stress fracture, you might need to have MRI imaging of that particular body part. Ganglion cyst, they occur in the wrist most typically. This is a T1 fat-satted, T2 fat-satted because it's bright. We know cysts are usually benign tumors. Labral tear, and the most common labral tear is that slap tear, which is our superior labral tear from anterior to posterior. So if you see that acronym, that's a labral tear. It's a sharp popping or catching sensation when you're doing certain shoulder movements. So when you have that orthopedist kind of manipulating your arm and you hear that pop, that could be a slap tear. And then rheumatoid arthritis. We know we do the ball catcher's view for the x-ray. but you can better diagnose this with MRI. So this is chronic inflammation disorder affecting a lot of the joints within the hands or the feet. Usually is pretty debilitating. Does anybody have anybody in their family that has it where they can't really grip things? You can see like their joints really start to swell up. Get a lot of bone erosion, joint deformity associated with rheumatoid arthritis. All right, so that's pretty much all your upper extremity MSK. So we can, we have a couple lectures before we even have to test on this. So we can take a little bit more time if we need to cover more in depth our physics, okay? So if you have questions, bring them to class. But remember, next week we have the quiz on flow right after we go over the second part of our lecture.